Without further ado, here's Dr. Bremner.
So thanks very much, Susie. It's really a pleasure to be with you here this afternoon and talk about this quite interesting initiative that has really taken off, I think, perhaps even beyond the expectations or dreams of the people who put it together. So it's been fun to see over the last couple of years. I was asked to talk about from national to local. I'll cover a few things that the ABIM and the ABIM Foundation, the American Board of Internal Medicine and its closely related foundation have been involved in from early on, and then touch on a couple of local things. I know we'll have many things about the local application of this later, but I'll cover a couple of them that are particularly to UW Medicine as well. In academics, at least, it's expected that you give a statement at the beginning about your various personal commitments, and so I have a long list of them, including support for my department, my own research program, do consulting for both public and private entities, and particularly to this conversation, I'm on the board of directors of the American Board of Internal Medicine. So this probably is a quote you may have seen before, may see again this afternoon, which is that choosing wisely as an initiative of the American Board of Internal Medicine Foundation, and the goal being to help physicians and patients and really engage in conversations about potential overuse of tests and procedures, and to support physician efforts to help patients make smart and effective care choices. I think it's important to stress from the beginning that the people putting this together did not want to put out a list of thou shalt nots and give the impression that it was really bad or malpractice or something to question some of these tests and procedures, but rather, as it states from the beginning, to foster some degree of comfort between the patient and the physician or other healthcare provider, to bring up the topic of whether a test that's being considered is actually necessary, safe, and cost-effective. So why was it initiated? I think really the underlying motives, although it gets a lot of discussion around cost saving, really the underlying motive was to try to assure best care for patients and families. They might be questioned because there's inadequate evidence of effectiveness. They might be questioned because there's the possibility of doing harm. They might be questioned because of high cost. But those were, as I say, the initial motivating goals. A very influential paper was published in 2010 by Howard Brody in the New England Journal. And the title of the paper is listed at the top, that it's medicine's ethical responsibility to deal with some of these issues and propose the top 5 list concept. And that this concept of proposing a list has the advantage that if we restrict ourselves to the most egregious causes of waste, we can demonstrate to a skeptical public. The we he's addressing here is doctors predominantly. But is, of course, expanded to other healthcare providers and systems as well, can demonstrate to a skeptical public that we are genuinely protecting patients' interests and not simply rationing healthcare, regardless of the benefit for cost-cutting purposes. And again, this is really a challenge to the physicians, and the fact that the challenge was taken up and implemented by lots of physician professional societies, I think, is the thing that makes this whole effort, if not unique, at least highly unusual, and has been why it has, I think, one of the main reasons it's got as much attention and legs as it has. So, carrying on the concept of the top 5 lists, the ABIM Foundation put some money into the National Physicians Alliance to pilot the concept, work on it, develop some initial 5 lists with various professional societies in family medicine, internal medicine, and pediatrics initially, and published a paper in the Archives of Internal Medicine detailing that and additional subsequent cost-effective analysis on what the what the cost savings could actually be if this concept were advanced. In April 2012, actually by some strange lining of the stars, we had Christine Castle, who was the president and CEO of the ABIM and ABIM Foundation here in Seattle on that day, April 5th, 2012, for a visit and to my department, and she gave medicine grand rounds and so on. The 4th and 5th were the days that this was publicly announced nationally, and she was on all 3 or 4 nightly news the night before, and it's a full-page article in the Seattle Times the next morning. It made me look smart. I was happy to take that. It was not designed that way, I can tell you, but it was fun. Anyway, she announced and the foundation did announce the initiative those days with the groups listed at the top here. I'm not sure whether you can read those, but I think it's in your handouts as well. The initial additional 9 societies that joined in April 2012. And then by the next year, a much larger group joined at the bottom. And this is getting very small in proportion to how many societies there are, I guess, are coming in this year and early next year with their list of 5. Some of them are putting together their second list of 5. So there's, I'm frankly not quite sure, in the hundreds now of recommendations if you total all these up. Another very intriguing part of this has been how much this has been taken up by consumer societies. And many of these were in partnership with Consumers Union or Consumers Report. And the AARP was early on. Both Consumers Reports and AARP meet each year with the ABIM and the ABIM Foundation. So they had good communication before this initiative started and immediately took off with it in 2012. And many more groups, including us here today, the Puget Sound Health Alliance, were early adopters and implementers of many of these goals. So these are and again, you'd probably have to look in your packet to see this, but these are the kinds of lists that 5 printed in this format coming out of each of the professional societies with what should be questioned at the top, and a couple of bullets about why it should be questioned. And if you want to look into it, there's references to back it up. Many of these comes out of the society's guidelines, and I've been intrigued with talking with John Nenadami, my GI division head, who chaired the American Gastroenterological Association's group that put together their 5, and how much blowback he got from the GI community, even though most of them were part of their published guidelines to start with. But putting this much attention on it woke up a lot of practitioners, both for good and for resistance. Anyway, for example, the ones in cancer were picked up quickly by, in this case, American Society, were produced actually by the American Society of Clinical Oncology, ASCO, and then were picked up by Consumer Reports and the ABIM, and rapidly were disseminated in publications of the both professional groups and of the patient groups. Interestingly, were picked up by entities such as the National Business Coalition on Health here with guidance about materials for employers. Do I have a pointer? Anyway, materials for employers can be accessed. Materials for employees, tip sheets, resources, and so on were rapidly formulated and put out for public use. Additional societies, in this case the Society of Hospital Medicine, choosing wisely again to improve patient care is the lead headline. Many societies started making apps for your mobile devices that you can check which echocardiographic study in this particular instance would be appropriate in which clinical setting. Obviously, one of the challenges in this area is if you're in general or family practice is trying to recall 200 or 300 guidelines, and so whatever devices can be made available, so much the better. As I'll touch on, though, in specific practices, you can put these things into planning patient care patterns and sort of hardwire them. But if you have a more general practice and 200 of them may be relevant, it can be challenging. So anyway, having some of these handheld apps has turned out to be popular and used. Individual practitioners, as a part of their medical society efforts and so on, have taken it up in this as well. This one comes out of Iowa with a practice internist presenting it at their CME courses and so on. Intermountain Health out of Salt Lake as an example of a major healthcare provider, similarly taking it up with implementation. The public media jumped all over it. I touched on the Seattle Times coverage of Chris's talk here a couple of years ago, and within a day or two it was a lead editorial in the New York Times, and went from there in terms of both public and professional journals reporting on the enterprise. Then to touch briefly, I know there's going to be much more of this afternoon, so I won't take too long on local initiatives, but just a couple of examples out of our own UW Medicine practice sites. The first two here are out of really my own department, and one in coordination with surgery, that is lung cancer. So the recommendation is no chemotherapy in late-stage lung cancer. And the implementation done by Renato Martins at SCCA and Doug Wood in surgery is to put this in the institution's care planning and pattern for that category of patients, so that the nurses and coordinators, patients, families, everybody knows what is to be expected at certain stages and when chemotherapy would not be given unless the patient were on a clinical trial, and that, for example, no blood cell stimulatory factors would be used in almost any case, and instead, rather, there would be a decrease in the chemo dosage, just as a couple of examples in cancer. In digestive disease, not to repeat colonoscopy within 10 years of a negative study unless there's a particularly high-risk family or other indication. And similarly, do not repeat normal endoscopy in Barrett's esophagus in less than 3 years. So these are the kinds of things that have been a part of the GI community's guidelines, but still got some blowback when these were made part of Choosing Wisely, but can be implemented practically in our environments. Let me touch on a couple of things in training. This one, I started talking to my chief resident as I was preparing for this talk and said, what are you actually doing with this? Do you know what Choosing Wisely is? She kind of said, well, yes. And it turned out she had been using this in a report the week before, which comes out of the American College of Physicians, which is the national practice group for all internists, 120 or 30,000 internists, plus AAIM, which is the Alliance for Academic Internal Medicine. So the practice community with the resident and fellowship training groups, anyway, had put this together, and it's being used in our training program. So with the learning objectives, including the traditional ones of what you do with a certain presentation and how do you treat the patient, but also something around the problem of healthcare waste, the roles that residents and attendings in our environments have, and brainstorming about how to address it, and then touching on a couple of clinical problems of headache and congestive failure. So presenting a patient, as we always do, of one presentation or another, in this case a woman with headaches, should she get head imaging, going to the Choosing Wisely, which says don't do imaging for uncomplicated headaches, and stressing the point that that is actually not an indicated study in that situation, and dealing with the patient in a different way. So these have been adopted into our own environments in terms of our student, resident, and fellowship teaching programs. Of course, you'll hear more, I think, about Washington State Medical Association initiatives, certainly the newsletter, physician programs. The president came to talk to our practice plan a couple of months ago, and he was stressing the choosing wisely as one of the main foci of activities of the State Medical Association. This is the local chapter of the American College of Physicians. Carrie Horwich has been up in Bellingham in this yellow thing, if you can't read it, on September 7th, giving a session, perhaps not totally dissimilar to this one, on choosing wisely. She's the governor this year of the local Washington chapter of the ACP. Of course, there's some challenges in this for both the patient and the physician. If the patient is committed to having a low-value service, having to go through the explanation that more tests and treatment are not necessarily better can be challenging. It's at least time-consuming. And the docs and other providers concerned about dissatisfying the patient. The patient's potentially worrying that somebody's just trying to cut costs. All of us in our professional training were told to obviously make the individual patient our primary goal, and so there are challenges in dealing with these sorts of discussion. There's a little underlying fear of litigation if the next test isn't done, and some tendency to accede to the patient's request. There are programs being put together to try to do a better job of teaching physicians and other providers how to have this sort of conversation. One in our environment is Tom Gallagher, from whom I got these couple of slides, who works a lot on patient-physician communication. The other one that might not be so necessarily thought of right off is physician-to-physician communication. And if you, if your patient has whatever presentation and you quote-unquote order an MRI and or a CT, and the radiologist calls back and says, this actually isn't really indicated and might do more harm than good. Those can be challenging conversations. So some effort to address that prospectively is being initiated as well. And we're doing that, for example, between medicine and radiology, to try to find what may be hot button areas and deal with them prospectively. But this is not an area that docs have been well trained in. A few concerns. I touched on the fact that there's over 200, maybe Pete was telling me 400 recommendations now. And so it's a challenge to focus and even to remember what all of them are. And then there's always the nagging thing that every once in a while, an unindicated test did a patient a lot of good. And all of us can remember situations of that sort. And frankly, it just happened to a person who works in my office a few months ago, got an abdominal CT for what was probably a viral gastroenteritis, and found a chest mass. And she had a very unusual but potentially fatal lung tumor, and had it taken out as the result of a probably unindicated study, and has done very well. So, those, for every doc, I think, can remember things like that, and that is banging around your head someplace when you're talking to the patient about why not to do something. So let me bring it to a conclusion and just state that the Choosing Wisely initiative, as I stated, is unusual, I think, because it's the first major effort by physicians to question themselves and their associates and their patients on whether certain things that are commonly done are actually useful, might potentially be harmful, and might potentially be inappropriately costly. It has been surprisingly widely accepted, not universally accepted by any means, in physician groups and in groups representing patients. Key issues now, as we'll talk more about, are how to appropriately implement the recommendations. So, in conclusion, the doc is saying to the patients, all your labs are back. They show a serious overuse of unnecessary and inappropriate tests and procedures. So then there's a list of additional information at the back of your handout. So, thanks very much.